Good afternoon, everybody, and we have a very exciting session lined up, and may I request our chairperson, Dr. Mahesh Shanmugam sir, to take over the mic.
Thank you. Let's start with the first presentation. Can I have Dr. Subhadra Jalali? She'll be speaking to us on scleral buckle in the era of vitrectomy. I think the presentation is for 3 minutes or 4 minutes. Is there no discussion time?
While they're loading my slides, thank you for having me here. I don't think I could have been a vitreoretinal surgeon if I didn't know buckles. And it's a great technique. I'm thankful to my teacher, Dr. Das, and Professor Amod Gupta, who taught me buckling. In fact, in PGI, I spent 3 months extra just to learn buckles. So that was at the end of my residency.
Can you show the slides, please?
So if we talk about scleral buckling in the era of vitrectomy, I think both are there side by side. To my mind, there's nothing like era of vitrectomy. Can we have the slides, please? Okay. So I just go back 30 years when I published this paper along with Dr. Das, and you can see here that case number 4. Even today, after 30 years, the only surgery I would do would be a small buckle for 20 minutes and not go in and create, multiple surgeries and do all those things. And this I can do in a non-retina theater, so I don't need 3D systems to do that. And so what I want to highlight is, I'm going to show you just few cases where the buckle scores over vitrectomy. This Stickler syndrome patient, left eye, underwent vitrectomy in my hands 20 years ago. And over a period of time, vision dropped from 20/40 to count a finger because of the band keratopathy, because of progressive glaucoma, and now he's almost blind. Where the right eye, with the reg RD, we put a buckle, and that's it. Even if he doesn't come for follow-up, I'm very pretty sure that his 20/60 vision is going to be there for lifetime. Old chronic RDs, again, if we try to do surgeries in these patients, the vitreous is bad. The subretinal band removal requires a lot of maneuvering. There'll be hemorrhage, and then all those things. So you just put a buckle, and the retina will reattach. And this patient has 636 vision for life. I would not be able to manage all these cases of ROP, FEVR, with tractional detachments if I didn't have a buckle. So these children, we are putting a belt buckle. You can see the retina flattens, and the fold also opens up, and for whole life, they are fine. This was very exciting. I did a buckle along with some imbrication in 2 quadrants, and you can see here this child from Bangladesh. I didn't have to do a lensectomy, vitrectomy, try to open that fold and create a unilateral aphakia. A single 240 band with imbrication opened the fold, and the whole ROPs, become stable. In retinoschisis, in selected cases, if we can do a buckle, there's nothing like that. These are young patients. The surgery is very difficult. The planes are not very clear. But in a patient like this, where you see even the RD can be missed. The center has RD, the side has RD, and a buckle will cure for life. Somebody is using the phone. Please switch it off. इनको बोलिए प्लीज़ फ़ोन बंद करने के लिए. If you have subretinal bands which are not tenting up the retina, then this patient had a buckle, and after a few years he had buccal exposure. We removed the buckle. Nothing is happening. He is very happy with whatever vision he has. Even if we do a vitrectomy, that macular change is not going to help him. The imbrication technique, which I have now done very well, along with the buckle, adds to the value, as you can see in these very complicated detachments. So it's not that buckle is used only for simple detachments, but for very complicated detachments where you would be lost trying to remove the vitreous and try to put oil. You will never get what you can get with a single buckle along with the imbrication. Where would you land in this patient? You don't know where the vitreous is, what you're trying to remove. The retina is so thin in the periphery. Any attempt to do a vitrectomy is going to lead to problem. Your buckle with imbrication, if needed, can lead to a 20/50 vision with a single surgery. So to conclude, buckles have very few sight-threatening complications. Fewer follow-ups are required. It's long-term stability. I think This gives the surgeon the versatility to use the appropriate technique for appropriate pathology and customize to each patient rather than vitrectomy, silicone oil, membrane peeling, endolaser for each and every case. The single surgery success is very high. Please learn and teach your residents and your fellows how to do a good buccal. Thank you.
Thank you, ma'am. That was wonderful. I'd like to ask you, are there any particular cases, as you've shown really difficult ones, where you will not use or not advocate using a tamponade in any particular situation? C3F8 or?
Yeah, so a lot of these high myope stickler syndrome, almost 100% of them will get glaucoma after you do a vitrectomy silicone oil. So I would always try to look for an opportunity to do a buccal rather than a non-vitrectomy case. All these cases, there's no tamponade. All these cases, this buccal with or without drainage.
Ma'am, what I meant was in a buccal, you will not use C3F8 or SF6, like for the traction. Like
all the cases that I showed you, there was no tamponade. Actually, there was no internal injection also. Most of them, we didn't even have to inject. If you're doing good buccal, you may not even need to inject something. Very rarely, if there's a lot of hypotonia after drainage, I might inject a ringer. Sometimes, if it's a spear HST, I might inject a bubble of air. But if it's a failing buccal, then I might inject C3F8. C3F8 or these gases, they can cause more shearing and they can develop new breaks. And then my population is all pediatrics. It will cause a lot of amblyopia because the gas will not go. They will not lie prone for such a long time. So really, there's very few cases where somebody might need a tamponade. Most of the cases, if your buccal height is good and you're able to do a good job, you don't have to inject anything.
Thank you, Dr. Subhadra. Does the panel have any questions or comments? Thank you, Dr. Subhadra.
Thank you.
Shall we go on to our next presentation, which will be by Dr. Sri Haranathan. He'll be speaking to us on dye-based break marker in scleral buccal surgery.
Thank you very much for giving opportunity to talk in front of the grandmasters. This is
Mic is off.
Yeah. This technique that can be useful not for the experts, it's for the trainees who are starting the career.
Introducing Shree's dye-based Retina brake locator, a breakthrough in scleral buckling surgery. Enter the realm of retinal surgery with this innovative device, conceived by Dr. Sri Haranathan, a pioneering Vitreo retinal surgeon at the National Hospital Kandy in Sri Lanka. Dr. Sri Haranathan is the trailblazing creator of the retinal surgical instrument, making him the foremost retinal surgeon to design such a groundbreaking tool. In a market filled with various scleral depressors, this instrument stands out for its exceptional capabilities. What sets this remarkable tool apart is its unique dual function. Not only does it serve as a reliable scleral depressor, but it also empowers surgeons to accurately mark the borders of retinal breaks using any ophthalmic dye. This innovation is a game changer, especially for surgical teams operating in resource-constrained settings. It features a handle with one end connected to a depressor, culminating in a spherical knob with opening measuring 23G. The other end can be seamlessly connected to a 23G infusion tubing. Inside the instrument, there exists an internal lumen that stretches from the knob to the handle's proximal end. This lumen acts as a conduit, facilitating the transfer of dye from a syringe to the distal knob, where it gently stains the sclera. At first, the retinal break is pinpointed using Shree's dye-based Retina break locator without the presence of dye. Once the break is precisely located, the Shree's dye-based Retina break locator is primed by loading it with dye up to the opening of the knob. Under the wide-angle viewing system, one edge of the identified break is gently injected with dye by an assistant, ensuring no spills occur. Subsequently, the wide-angle viewing system is removed and the globe is rotated to visualize the mark while keeping the Shree's dye-based Retina break locator in place. After obtaining a clear view, the Shree's dye-based Retina break locator is carefully removed. The location of the break is now distinctly marked on the sclera, And this mark is then further delineated using a skin marker. Dr. Cherith Fonseca, true pioneer in the field of vitreoretinal surgery, a senior consultant and the founder of the Association of Vitreoretinal Specialists in Sri Lanka, says, "I am really impressed with this instrument as it is able to clearly mark the anterior and posterior margins of the tear, which enables accurate placement of the buckle and minimizes its size. In the field of ophthalmology, accurate identification of retinal breaks is vital for the success of scleral buckling surgery. However, this task can be challenging due to the difficulty in marking the break on the sclera. Dr. Sri has developed a revolutionary device to address this issue. Dr. P. Mahesh Shanmugam, head of the Vitreoretinal and Oncology Service at Sankara Eye Hospital in Bangalore, recognizes the game-changing potential of Dr. Sri's device in enhancing the precision and success of scleral buckling surgeries."
Thank you.
Any particular, if you have a very small break, so what will be your approach to sort of, for this?
Yeah, I don't use the dye for each and every one. First, I tried with the knob. If I can't see the mark, then only I go for this, use the dye as a second choice. If it's a small one, you don't need just a single mark is enough. The break is large, so I can gauge the size of the buckle by marking all the anterior, posterior, and side points. So the buckle may be exactly matching the break.
Thank you.
Thank you.
Yeah, this addresses the issue of marking on the surface as clearer, but then one of the issues which we have is usually the perfect localization, which is usually a problem for the novices, because we are not too sure with the shaft indentation or the tip indentation when we try to localize. So one of the modifications which you can do is to use a used 20-gauge light pipe. A 20-gauge light pipe is a little bit sturdy. You can bend the tip and connect it to the light source, so that we have an illuminated localizer. So we can see inside, the tip of the light is seen inside, and so we can precisely see that's the tip of the instrument, not the shaft of the instrument, and you can use that for precisely localization on the surface. That's something which is useful for the novice surgeons as well. Are there any other comments or? Thanks, Dr. Sri. We'll go on to our next presentation, which will be by Dr. Suguneshwari Ganeshan. Dr. Suguneshwari, she'll be speaking to us on macular buckle.
A very warm good afternoon to all of you. So I'm going to be talking on macular buckle. So this is going to be another extraocular surgery. My mic is not.
Suguneshwari is not heard, is unheard of.
Huh? So warm good afternoon to all of you, and I thank the organizers for giving me this opportunity to be talking on macular buckle, which is going to be an extraocular surgery.
Please.
The mic, yeah.
Yeah.
Yes. So we're going to be talking on high myopia. So these are patients whose spherical equivalent is above -6 diopters, and the axial length is more than 26.5 millimeter. So what is myopic maculopathy? Here, first, I would like people to understand why we do these buckles, because these buckles are more easier than anything, but you must understand where to do and when to do it. So there are multiple classifications. One among them is the Etienne classification, where the first thing talks about the atropic myopic maculopathy. And in this, all the components are like you must have the excess axial length, which I had already alluded to, and the posterior staphyloma. And the next one is the tractional myopic maculopathy, where it starts from T0 to T5. So this is what we are going to be talking today, dwelling on this particular subject. So T0 means there is no macular schisis. T1 is you have inner and the outer schisis. I'm talking about the foveal schisis here. T2 means inner, and the outer foveal schisis, and T3 is foveal detachment, T4 is a full thickness macular hole, T5 is a macular hole with a retinal detachment. So next is the neovascular myopic maculopathy, which I am sure the others are going to be talking in the other session, so I'm not going to be talking on that. So now the other system which is there, which is quite now most the talk of the country or talk of the globe, I must say. So it is the myopic traction maculopathy staging system, which is called MSS. And in this, you should understand there's a retinal pattern, there's a foveal pattern, and there is an evolution. This is most important. So you label it as staging. The fovea, you talk about A, B, and C, and you also understand about the evolution. So you know the stage 1 to 2 takes 20 months nearly, 2 to 3, around 12 months, and 3 to 4 is 3 months. So if you add something like ROP when we say, plus and like that, here you have, if you use an O in front, then it is outer lamellar macular hole. If you use a plus, which means epiretinal membrane. So now here it is all about the game of forces. The forces means intravitreal forces, then the forces enacted by the sclera. So we must understand, go back to the Curtin's classification where he described about the 10 types. So type 1 being the very commonest one. Now here is another classification which is given by our Japanese colleagues, which is most simpler to adapt. So this is from type 1 to the 6, 5 until 5. It's easy to memorize also. So type 1 is a wide macular area, type 2 is in narrow macular, type 3 is peripapillary, type 4 is nasal, type 5 is inferior, and the others. So now with this understanding, you should understand that when we are talking about these posterior staphylomas, you have a little lesser curvature from the sclera, which is an ectatic sclera, and which is also seen on the ultra wide field prototypes to understand where exactly the staphylomatous areas are. Because of these tractions is why the changes takes place. And you could use an ultrasound to classify it as mild, moderate, severe, very severe. Once we know these things, then we will know how to do it. So what are the ways in which you evaluate a staphyloma? By ultrasound, wide field fundus photography, the MRI is also being used, and the SSOCT as well. So now, this is in short the myopic traction maculopathy, the MTM, which is called, the first one is the schisis, the second one is the foveal detachment, the third one is the retinal detachment which you have. And also now the last panel, you must see the defect is all now in the inner surface. So if you have a lamellar macular hole, the full thickness macular hole, or the macular hole with retinal detachment. So these are the ones in which we should do the macular buckles. Now going by the pathogenesis, the pre-retinal factors, the subretinal factors, and the factors limiting the retinal elasticity. So the principles are in short, prevent an axial elongation, shorten the eye, flatten the sclera, create a dome-shaped macula, and a non-drainage procedure. So here we have multiple evolution. The endosplom, which is the one which was used by the Japanese colleagues. So you identify, the most important thing is identify the 4 muscles which we all tag. The superior oblique, inferior oblique, you must hook it, and then the placement is along the lateral rectus so that it goes underneath the macula. So this is a scleral sponge, which is a 507 sponge, and this is L-shaped. You make it L-shaped by making the titanium stent, which is being used. So people have used multiple materials. Here somebody has done an orthodontic stainless steel wire. So these are all done to make these sponges easily into a flexible surface. So now our experience here is with a T-shaped buckle, the Morin-Devon's buckle band, and here the Morin goes under the macular plate. The Devon is a 2 millimeter solid silicon band which goes through the Morin. And here with our experience, what we have seen is the axial length reduction from 28.5 millimeter to 26.2. The visual improvement was seen in 40%. The complications are there with subretinal hemorrhage, hemorrhagic CD, the angle closure glaucoma. So you need to know when you will do what? The macular buckle, or would you do a pars plana vitrectomy, or you would do a combination with a peel, without a peel. How do you go about that? If you have a detachment, please understand it is a macular buckle. If you have a schisis, it is a macular buckle. If you have a defect in the inner sensory retina, you would do a combination of a macular buckle with a PPV if you are having the associated defect also. So then this is what it is to understand. The complications, as I've already alluded to, 78% is what I would like all of you to remember. It is the tilted disc syndrome. This is one thing which we should carefully see. If you have something like a tilted disc, then your macular buckle can be associated with a lot of complications. And now I pose in front of the audience one question. I will
Time
finish
is
it.
up. You need to wind up.
So in short, this is what it is: myopic traction maculopathy, where buckles are being placed, and where a macular buckle with a vitrectomy, and that's it. Thank you.
Thanks, Dr. Subramanieshwari. Dr. Subramanieshwari made it look very, very simple, but I'm not too sure if it's that simple. So I would like to ask the panelists, like, how many of you, I'm sure like most of us are not doing macular buckles. I have done a couple of them, but then I'm sure most of us are managing with vitrectomy. So what do you think is a clear indication that the macular buckle is required, Dr. Dinesh?
Yeah, so frankly speaking, I think I wouldn't do a macular buckle in most cases. I actually have found very good results with complete ILM peeling from the arcade to arcade, basically the entire area of the staphyloma. So if you take care of the vitreoschitic layer, the first thing is that you often have cortical remnants of a vitreoschitic layer. You know, sometimes it's a full layer, sometimes it's small parts of it. If you take care of that, then you take care of the entire ILM from the edge of the staphyloma all the way. Most of the time it settles. In fact, I was just seeing the results, not talking about, you haven't told us how many actually settled. Because if you have a detachment without a hole, you don't even need to put oil. It will settle, over, but it takes a few weeks to months.
Okay. Dr. Naresh, would you do a macular buckle?
I have never done that.
So,
And some of it is not that freely available also.
correct.
So
it's not available. The
it's not freely
Warren
available.
Devin
Unless
buckle
otherwise
is not
it's available for everyone to use.
Correct.
In fact, I would like to know, I mean, I am concerned about its safety because the entire short posterior ciliary nerves, arteries are in that area, and you're blindly going into that area. So what is the risk of damage, and how would you assess whether you've damaged or not?
So it is like when you are passing the buckle, sir, it goes, you don't make tunnels all around. You just have to see that the tunnel, see there are many buckles you can decide. If you are using a Morin's one, then you need to go only through the superior oblique and the inferior oblique. There is no tunnel. It just goes underneath that, and you are lodging only the macular plate goes along your lateral rectus and then goes underneath. It's actually quite simple when we place it, because I placed it on retinoblastoma children when I've had a break at the macula. So, and you have a tumor, you have a break also. So, and one single eye, then you have no other opportunity to do. So these are circumstances where unusual circumstances when we do. But here we are not talking about the routine myopia. These are very high myopic eyes where the axial length is more. And if you have already a failed vitrectomy, all of us do have that. When we No, there are cases in which very selected cases.
But like it has been like this, like as I mentioned, despite all these discussions go on between like all of us as well as Barbara Parolini and one of the Egyptians, I think it's still not clear, because I remember one patient who was actually posted for macular buckle by Dr. Pradeep in Shankar Netralaya. The patient is from Bangalore. Then she went to the airport, she fell and broke her arm, and then she couldn't come to Chennai, and then she came here. So I did a vitrectomy, it settled. So that's how it is. So it's like, yes, it's not very clear. We will leave it at that. But then like I usually do a macular buckle if there's a recurrence or if there is a failure,
yes,
with a macular hole under full thickness retinal attachment, full thickness macular hole under retinal attachment.
Yes, agreed, sir.
Thank you.
Yes.
Thank you, Dr.
Thank you.
Subramanieshwari. Thank you so much.
You mean to say if the patient has got macular schisis with fracture of arm, they've got a better prognosis?
Correct, I agree. And if the patient has to go vitrectomy if the patient falls in the airport. So shall I have the next presentation by Dr. Pramod Bende, who will be speaking to us on managing PVR.
No, sir. I can close this.
Yes, sir. You can have a question, quick question. And maculobuccal complications, like whatever, in addition to whatever Dr. Subramanian mentioned, the patient usually complain of a black patch. So it's not as though like there is hypoperfusion or something like that. They do complain of a black patch, and sometimes they complain of seeing everything black and white, and then subsequently it changes over the years.
So Barbara won't never agree with us, but there are chances of macular atrophy, as Dr. Dinesh was trying to
Correct.
make out.
Yeah, but the question of macular atrophy is you don't know, because these are again already myopic eyes with staphylomas and an atrophy. We don't know if it's getting worse. But then yes, I have had patients complaining of a black patch, translucent patch. Then they see black and white, and then they kind of recover.
No, actually, just to add on that, just make things a little bit simple. You need to assess where you have anterior-posterior traction and where you have a tangential traction. So you have tangential traction, your ILM peeling helps very well. And that's the reason we always do MRI, we always do ultrasonography. We assess the depth of staphylomas, and too deep a staphylomas, associated macular hole. All this combination buccal does help. And most of the time, this buccal is combined with vitrectomy and also added with ILM peeling, rather than a very rare situation where only buccal we did. Because that's a practical difficulty there. Because what you said is right. Most of the cases, initially what I was also doing, we did ILM peeling. Retina settled where, but when you settle, the gap, residual thing, with as if type 2 macular hole closure. It remains like this, and vision did not improve. So that's the reason we decided over this particular case, very deep staphylomas, obviously, and then you go ahead with macular.
But Pramod, even with a type 2 closure,
does the macular hole close?
Those cases, sometimes it closes. Not all the cases. Again, see, this is again unpredictable thing.
That's the issue. But not that like you put a macular buccal, the hole closes. Sometimes it may close, but at least the detachment doesn't occur.
Yes.
But Pramod, actually, even with a type 2 closure, you can still get visual improvement.
No, it will be better. It is better than sometimes. Sometimes it improves, but what again, underlying atrophy, it can be pre-existing atrophy. We all know, like a big myopic degeneration is always there, whether it is induced because of buccal or it is a process of myopic progression. It's anybody's guess.
Okay, we'll go on to the next talk, leaving that question of maculobuccal or
Thank you very much for having me here. So, Yes. Okay, fair. So just a word, classification, A, B, C, D. No, I don't go into detail about that. So what you're coming to PVR straight, see, you can see a variable pictures, and that's why your management change accordingly. Case to case, you have to variable. Those scleral buckling, still all of us agree. Dr. Subhadra said, gold standard, particularly uncomplicated cases. However, most eyes with advanced PVR, they are not amenable to scleral buckling and would need vitrectomy as well. So, if you are planning combined buccal, obviously you open conjunctiva. I still prefer, if you have given option, I at least add encerclage, all these cases. And what is important here is when you deal with these cases is membrane dissection and how you handle this. Basically, is always instrument is a surgeon's preferences, but goal is to relieve all the traction to make the mobile retina, what you see top picture, to get something like this at the end you want. And technique again depends on location, extent, vascularity of the membranes. You can use bimanual or unimanual section, and depending on particularly want to make the retina more mobile. Fortunately, of course, PVD is an important criteria for all of us. But in most of these PVR cases, except probably pediatric age group, I would say posterior hyaloid is already separated. So when you talk about this critical stage, how to peel, you may have focal PVR, and then easy to use peak or forceps or your cutter. Now there's 25 or 27 cutter to create the edge between those folds, get the edge and use your forceps to peel that up, and your job is done. But sometimes it does not work that way. You have membranes are extending, retina is mobile, and the second video as you see, and as you try to peel off, you don't have counter traction. You have, and then use a disc probably as a counter traction, peel from center towards very slowly, try to tease them up, and if necessary, occasionally use your light pipe to support the retina there, hold it back and peel the membrane off. You are not pushing the retina too much, but basically light pipe will help to hold it on. Yes, the most important factor for all of us is identifying immature membranes. You see, sometimes practically you can't see any membrane initially, but as you keep on teasing, massaging retina, slowly you get those thin, flimsy membrane. Indication would be sometimes lot of pigments you see on the retina, and that's another indication. It starts teasing, and when you get that age and start peeling, probably you realize here that entire retina was covered with the membrane, and you need a lot of time to spend with him, lot of patience, go around, keep on, and because these membranes are fragile, they just come at bits and pieces. So it's not like that you start peeling and every day, one go they will come compared to mature membranes as you saw. So you really have to go every millimeter of retina, inch by, and slowly get whole thing out to ensure retina is fully mobile here before going to other steps. Yes, membranes are sometimes tough. Periphery, either you can use directly bimanual, is the other video you see, but sometimes your light pipe itself can act as a bimanual second instrument. So here what actually I was doing is membrane is holding with the forceps, not peeling the membrane, because if I try to do that, probably sometime I will tear the retina because counter traction is the issue. So hold the membrane, forceps, and push the retina back. As you see here, my light pipe is pushing here, I am not pulling with the forceps. So, and however, sometimes this is exactly what you should not do. You try to pull membrane here, the retina gets stretched, and sometimes you land up and trailing the retina, and the blood vessel give way here, and you land up sometime in a problem. So please avoid this type of complication as far as possible. Yes, these are anterior PVRs, tough for all of us. And most of these cases, we deal with a bimanual dissection. One was, previous session was shown with a keratoprosthesis trauma case. So anterior PVR, this was a 20-gauge video, actually, old one. Another one is giant tear. So hand on hand, you hold the membrane, tap the retina, and try to get the membranes out. But need, again, a lot of patience. Basically, things can be worked out if you are patient enough. Subretinal membranes, probably I won't go much detail because I think it will be the next talk. Somebody's talking about exclusively subretinal, so probably I'll leave it here. So additional steps, when you deal with a PVR, you may add scleral buckle or encircling band depending on where you need a support, vitreous base or aura. And if you were previously placed scleral buckle, usually we do not tend to remove. Retinotomy, usually if there is unrelieved traction or diffuse equatorial traction, foreshortening, or you have significant contraction and fibrosis probably, generally you use as a last resort, if at all. But once you decide to do retinotomy, you should be liberal enough, have a cautery done peripherally, and then cut those peripheral retina, but ensure anterior flap of the retina, which is necrotic, should be fully removed. Sometimes you can use one, but before that, remove all the membranes before attempting retinotomy. Probably put PFCL to stabilize the posterior pole rather than sometimes other retina is too mobile to settling it become difficult. But once that is done, with under additional PFCL to settle the retina and subsequent laser. And this is what we added some more PFCL to flatten the retina, and then you do laser all around here. And this was the end of the picture. Silicone oil, obviously, most of these eyes, I will not go because most of these eyes eventually will end up in a silicone oil unless they are superior isolated breaks and you get enough clear mobile retina. You may be able to get away with gas, but most of these eyes will need silicone oil. So to conclude, in detachments, periretinal membranes are predominantly due to exaggerated healing response, making retina stiff and immobile. Meticulous removal of all the membranes over entire retina is critical to remobilize the retina for successful reattachment and to minimize the recurrence of PVR. And choice of the instrument is obviously at a surgeon's discretion. Thank you very much for patient
Afternoon, sir. Excellent talk, sir. I would like to ask 2 points from you, sir. What is the role of intravitreal methotrexate according to you in these recurrent PVR cases? And second question is, sir, have you ever used heavy silicone oil in such cases, especially in inferior post-traumatic old retinal detachments?
Methotrexate, people already would have tried. People have tried Tricot, other issue. But I don't think we have, as of now, there's no concluding evidence that it is really beneficial. Even one of our colleagues were trying, once you do RR, he sprinkle Tricot all around, yes, and then put silicone oil over it, excess remove. But we have yet to analyze those data. We do not know whether it is beneficial or not. As far as heavy silicone oil, I do not have personal experience. In India, it is not as officially approved.
It is from Bosch and Lomb from USA.
People are using, but I personally feel there's no substitute to clean membrane dissection and settling the retina. Because with heavy silicon soil, whatever literature we read is, we have superior PVR. If you put a regular silicon oil, you have inferior PVR. So ultimately, that's what you will end up in.
Thank you.
So actually, we use methotrexate in almost all cases.
Sorry?
Methotrexate. So,
Methotrexate.
at the end of the surgery, 400 microgram and weekly 400 microgram, because half-life is only 5 to 8 hours. So it really helps. Actually, our paper is under review currently.
Good, we'll see.
And an alternate for heavy silicon oil is short-term tamponade of PFCL. We can retain it for a week or maybe maximum of 10 days, and then we can replace it with silicon oil.
We'll wait.
How many injections do you give?
Sir, at least for 5 till the end of first month we use.
So every week one injection,
every
5
week one
injections?
injection, intravitreal 400 micrograms.
Was it a comparative trial, Dr. Naresh? Or
Yes, sir, it's a comparative trial.
Okay, so can you share us the percentage
I don't
difference?
have the exact numbers now, but compared to the control arm, the results are better, sir. The reattachment is better.
But there's another trial.
Under silicon oil, no?
Under silicon oil.
There's another trial. I think the international trial is going on also.
Yeah, that is from, I think, by
So
We're not at the results. are not out.
Did you compare, Naresh Babu, did you compare this thing with a control group which is of similar degree of
Yes,
PVR?
almost similar, yes, sir.
So what is the difference?
No, the reattachment rate and the need for multiple surgeries is less in the methotrexate group.
So one question, would you advocate use of dyes for immature membranes, any kind of dyes or staining?
Actually, we can use most of the time, again, trypan blue, you can try, but most of the time we can manage. I personally do not use, probably tricot once in a while, just sprinkle a little bit, but not other dyes I not use. Because particularly when you have difficulty in inducing PVD, that's the time I use, but most of the time we manage it.
Immature membranes, what I would do is to stain the ILM with BBG and use that as a handle, because sometimes when you peel the ILM, then the immature membranes over the posterior pole get identified, and then we are able to peel it anteriorly.
The advantage, it gives a differential staining, so then you know that something is blocking there. That's the thing.
Actually, in patients who have, whom you're finding it difficult to settle after you've done everything, say you put PFCL and you still find it still lifted up.
Yes.
Sometimes it helps to remove the ILM as much as possible using staining with BBG. And before I come to the stage of retinectomy, I would actually prefer to give a buccal inferiorly. I mean, somehow I feel that doing extensive retinectomies leads to more hypotony as compared to a patient who gets a buccal 180 degrees inferior.
Yeah, that what I said. Most of the PVR, I still try encirclagement, and if there are inferior breaks, I would still put a broad buccal before doing retinotomy.
Yeah.
I still do that one.
Yeah, I think that's the basic message, that I mean, retinectomy is actually the last thing.
Yeah, it is
after
the last
everything is done. But there's a tendency to take retinectomy in the beginning itself.
Agree.
You know.
That's a last step always. Yeah, thank you very much. I'll take this opportunity to invite all of you also your next Retina Summit in July, and which theme will be ROP, and it is along with the Indian ROP Society as well. Thank you so much.
Thanks,
Sir, you asked for the numbers actually. It is 71% reattachment in our methotrexate group versus 45% in control group.
That's a significant number. So 45% versus 71% is a significant number. So let's wait for Dr. Naresh's paper to be published. We'll go on to the next presentation, which will be on subretinal PVR management by Dr. Jayan Guha.
Thank you so much, sir. And it's an honor to be presenting before this August gathering, and I owe everything to these two great institutions, Don Bosco School, Park Circus, and National Medical College, Calcutta. So,
Dr. Dhanashree?
Subretinal membranes, also known as retinal bands of membranes, are a well-recognized complication. They form a part of the spectrum of the whole PVR, as we all know. And in this process, just to a small word about the pathogenesis, RP cells migrate from their normal monolayer into the subretinal space and undergo metaplasia into macrophages and myofibroblasts-like cells that proliferate as sheets. Also, epithelial mesenchymal transition is the thing of the RPE which might take place and is involved in the PVR process. So the two main types, the diffuse cell sheets and bands. The diffuse cell sheets they lack there's lack of collagen in these glial cells, so they rarely contract. And these membranes are thin, and therefore they rarely cause any structural changes so as to necessitate any division or removal. So most of the cases, these cell sheets need not be removed. But the taut bands containing myofibroblasts which raise the neuroretina and impede the conventional reattachment anterior posterior is composed of 95% RP-derived cells with fibrin and collagen. This usually requires surgical division or removal. These are the morphological types of subretinal PVR: annular strands, linear strands, moth-eaten appearing sheets, as we see in these pictorial representations. And this is a very important study by Lewis, which stated quite early, a few years back, that only 28% of the subretinal bands require removal or transection during vitrectomy. And the second part of the study, they said that the patients who do not require removal have relatively better visual prognosis. This particular aspect has undergone a sea change due to the techniques and instrumentations that have evolved over the years, which I'm going to show. So we have to be also sure when not to remove these bands. As you can see, when I play the video, that these subretinal bands is extending from the macula right out to the periphery. So a simple depression test after putting PFCL, which will help you to ascertain whether it needs to removal or not. As you can see, if you depress, it plays along with the retina, and it doesn't. There is no tautness on, so the retina, the bands need not be removed. So surgical management of subretinal band removal is of PVR, as stated so eloquently and excellently by Pramod. In fact, Pramod's act is a very difficult thing to follow, as I was telling him. So closure and sealing of all retinal breaks and release of periretinal traction, these are two major principles. And to this, it's out of the scope of this lecture, but prevention of recurrence should be the part of management. Key points are that sheets, as I told you, they never cause enough force to prevent attachment. Bands sometimes have to be removed, not always. Like in this case, as Madam Dr. Subhadra had pointed out, that buckling surgery has a role, and these bands were settled by buckle alone. Of course, the case of detachment with subretinal bands, we settled, and these bands need not be removed. First, the techniques of removal are, if a retinotomy is there beside a subretinal band, so a separate retinotomy, you can remove the band through the existing break if it is adjacent to the band. And if a retinotomy is needed, so the location is very important. It should be beside the thickest part of the band, and the direction should be ascertained that the forceps should enter the tangentially and as tangential as possible. So the location of the retinotomy is very essential, as I will show in the video. So this is a pictorial representation, as I was saying. So these are the ways to grasp the band unimanually and bimanually, as will be shown in the videos. So I won't elaborate here. And principle, one should be careful never to use diathermy over a band to create a retinotomy, as this can sever the band. Sometimes these bands are strongly attached to the underlying epithelium, so best to cut these bands in places rather than removal, because that can lead to a lot of bleeding. But when there is a diffuse network of subretinal proliferation bands, then it's prudent to take resort, as a last resort, as Dinesh has said, of a retinotomy, which should be extensive if one has to make a retinotomy. So I would like to show you a tug-of-war technique which has evolved over the years, essentially started by Dr. Cyrus in epiretinal band removal, which can be extrapolated to subretinal band removal also by using two forceps or a combination of forceps and spatula. So this is the case where we definitely need to remove, as you can see. And there is a network, so we need a retinotomy to remove these bands using two forceps technique. The direction of the forceps should be tangential to the surface of the retina. That's the basic thing. So, and one can go very posterior if need be, sometimes up to the disc, but very carefully. Remove the extensive network of bands, and then you use perfluorocarbon to, after removing the bands, you use perfluorocarbon and settle the retina and do laser and PFCL silicone exchange. And just a small point regarding if you do a 360 retinotomy, then I usually give oblique cuts medially, nasally, and temporally, because otherwise there will be a PVR contraction folding. So this is a small trick. So this is another case where after repeat surgeries presented to us, with subretinal silicone oil, which was removed, and these bands were exposed. And again, thorough retinotomy was made because the retina had So I'll go to the next video. So just a small word about ab external subretinal removal. Wolf had started this, and here you make a retinotomy, but it's usually before the vitrectomy. Band removal is made, and Rupok here does a lot of the subretinal band removal here. So it's usually done, as I said, and this is the last part of the video, showing the tug-of-war technique. 2-minute video. So retinotomies are made adjacent to the bands and removed as is seen here. There were 2 areas where they needed to be removed. If it is localized like this, it's good to make a 2 small retinotomies, but these extensive networks need to be dealt with bimanually. And as I said, 2 forceps using, I'll just try to fast forward.
Can we conclude, Dr. Jayanta?
Yeah. And that's the end of the surgery, the previous one. And we go to the last part. Here spatula and forceps being used. And these 2 videos, the last 2 cases were, one had to combine with a retina, autologous retina transplant because there was a huge macular hole involved along with the RERD. And the last one is about foreign body. So,
Dr. Dhanashree, can you take to the dais?
Yeah, just finishing. And so this is a case where after removing the bands, then the autologous retina transplant was done, taking retina from the periphery. Here I'm putting the transplanted retina onto the large hole, and the last part is we remove the foreign body which was located, which got embedded near the fovea, and through the pre-existing break, the subretinal band was removed. Thank you so much for your kind attention.
Thank you, Dr. Jayant. We'll go on to our next presentation by Dr. Dhanashree. So like Dr. Jain said, that not all SRG need to be removed. The ones which are running across the macula and not allowing the macula to settle down would have to be removed either through a peripheral retinotomy, or in rare situations you would have to do a 360-degree retinotomy or a temporal retinectomy, fold over the retina and then remove it. We'll go on to the next presentation by Dr. Dhanashree, which will be tips for prevention of PVR. Yes, Dr. Dhanashree.
Good afternoon, and thank you for the opportunity. So this is like a revision talk because some of the discussion has already been done in the previous talk. And you know the PVR is very important because you see there are 3 talks dedicated to the PVR in this session itself. And nearly 80% of the recurrences or surgical failure is because of PVR. It can range from simple, few membranes, or it could be just a total, closed funnel. And this is actually a case which has been abandoned because of PVR. So the primary prevention of PVR begins with the treating of all the lesions such as the horseshoe tears or lattices or symptomatic lattices or holes or areas of subretinal fluid, because then there will be no RD and nor there will be any PVR. Also, primary prevention begins with prompt repair of primary retinal detachment, which will prevent PVR. Important things to note is that you should use less cryopexy because that is also supposed to cause more PVR, and also hemostasis should be done well to prevent PVR. But secondary prevention of PVR is more important, and that includes 2 things. One is the surgical measures, and second is the pharmacotherapy. So surgical measures is what we have already been discussing. So it begins with planning of sclerotomies and placement of infusion cannula. Sometimes with PVR the retina can be very anteriorly pulled, and it might be possible that the infusion cannula might be subretinal, like how you can see in this video. And if that is the case, then you can change the cannula temporarily. Make sure that your infusion port is clear of the retina, and then reinsert the cannula and start the infusion. But always make sure that the cannula is seen before you start the surgery. This is a situation where the entire 180 degree inferiorly there is a wound, and the retina and vitreous was incarcerated in the wound. So we have not given any sclerotomy in the inferior part, and all the 3 sclerotomies are in the superior part, and the infusion actually I have fixed at 12 o'clock. And so this prevented any retinal tear or injury which can occur right at the beginning of the surgery, which would of course make your surgery much more difficult. And in very extreme cases where you cannot put the cannula, here you can see the retina is in the pupillary area, and here I have placed one AC maintainer. So such things also can be done. The second tip is complete removal of cortical vitreous. It is of paramount importance to remove entire vitreous, including the vitreous base as well as the posterior hyaloid face, for your success of the surgery and to prevent PVR. Meticulous removal of membrane has also been stressed by Dr. Pramod Bhende. So all the membranes, whether they are immature, mature, small, large, all membranes need to be removed. And you need to spend enough time in locating the membranes and removing. So each fold of the retina and each crevice needs to be scratched to see if there is any membrane, and all visible and sometimes difficult to see membranes also need to be removed. If after removal of the membranes also you see the retina is crumpled, then there can be subretinal membranes, and subretinal membranes also need to be removed, especially those which will prevent the retina from getting attached. So here you see the retina was completely crumpled because of this large band of the subretinal tissue, and once that is removed, then the retina can settle very well. So the third tip is the role of liquid perfluorocarbon. So this is very important because the perfluorocarbon can help you work anteriorly when the posterior retina, bullous posterior retina can be settled, and it is can be supported by the PFCL while you work anteriorly and remove all the membranes. However, you have to make sure that it can also open up the closed funnel. However, you have to be careful not to inject the LPFC so that it can roll over the edge. So just short of the edge of the break, you should fill the LPFC only up to that level. This stage procedure has been described, and Dr. Naresh Babu here is a strong proponent of the stage vitrectomy, where in the first stage you do vitrectomy and leave the vitreous cavity filled with PFCL. The advantage is that no prone position is needed, and in the second stage, which is generally done 5 to 7 days later, the PFCL is removed and it is replaced with silicone oil. And so some surgeons, including Dr. Naresh Babu, have reported high success rate and low rates of PVR and recurrence of RD with this kind of staged procedure. Also, there was a mention of heavy silicone oil or Densiron, which can also be used to prevent PVR, especially for inferior retinal detachment or one-eyed patients, or in patients who have had multiple failed surgeries previously. Role of encircling band is again very important. We know that the encircling band supports the vitreous base and also the areas of traction. So if you have areas of traction, especially inferior area, which is a very, very high risk for developing PVR and recurrence, then it is a good idea to either support it either with an encircling band or a segmental buccal itself. So this will highly increase your chances of reattachment of the retina. Next is the take care of the anterior retinal tissue. So this is what happens is that when you do the retinotomy, you will see that the anterior retina is unsupported and unlasered, and this area gets contracted and leads to further recurrence. So it is very important that you take care of that anterior tissue and do laser, proper laser to this. Either you can resect it completely or you can do laser and make sure that it does not cause any problem. Adequate retinectomy again has been stressed. So the retinectomy has to go beyond the visible area of contraction. ILM peeling has been again advocated as a instrument to produce PVR. However, this meta-analysis which was done, it showed that the ILM peeling can prevent ERM and it can reduce the recurrence rate, but there was no added visual benefit. It may have a role in early PVR, but there is no role in advanced PVR. And pharmacotherapy, again, is very important. We know that there are some pro-inflammatory cytokines such as platelet-derived growth factor, TNF, TGF, and calcium-independent phospholipase. So these are seen to be involved in signaling and proliferation of PVR. And role of steroids, all of us use steroid very profusely, intraoperatively, preoperatively, as well as postoperatively. And this study by Dr. Tarun Sharma showed that preoperatively there is a role of steroids in vitrectomy and prevention of PVR, especially in cases where there was also choroidal detachment. This study evaluated the role of triamcinolone intraoperatively, and they said that there was significant difference observed, but there is a possibility that the triamcinolone can cause toxicity, and they actually did not recommend use of triamcinolone intraoperatively. Antimetabolites for prevention of PVR, as we just discussed, have been evaluated for last couple of years. 5-fluorouracil and daunorubicin have displayed mixed results, and also there was systemic toxicity to do these. Methotrexate is a promising agent, and several people are using it, including Dr. Naresh Babu. So as he mentioned, 400 microgram injection to be given intraoperatively, and then it has to be repeated weekly to reduce the PVR. But again, you have to take into account the chances of systemic and local toxicity, and associated recurrent detachment can still occur in high-risk patients. So the take-home message is prophylactically treat the lattices, horseshoe tears, and repair retinal detachment promptly. Plan the sclerotomies properly and the infusion cannula in the appropriate area. Remove all preretinal as well as subretinal membranes. Use PFCL to stabilize posterior retina. Can use encircling band to support the peripheral retina. The role of ILM peeling remains debatable. Preoperative steroids can help prevent recurrence, and methotrexate shows promise in PVR prevention. Thank you.
Thank you, Dr. Anashree. Anybody in the panel uses any other agents?
Mahesh, I have 2-3 points which I want to ask the panel also. And regarding prevention of PVR, especially anterior PVR, the most important thing is anterior shaving of the vitreous. If you don't shave the anterior vitreous, that's the scaffold where the secondary membrane, especially the anterior loop retraction, forms, and that's the most difficult to treat. See, an ERM, even if it forms at a posterior pole, I'm not so bothered. I will be able to treat it easily. But if the patient develops anterior retraction, that is very difficult to treat. So if you do a good shaving of the vitreous, especially the inferior vitreous, you can prevent that from happening. So that is one. Second, of course, you mentioned about doing the laser, and especially any doubtful areas. I would actually prefer to do laser from the aura up to the posterior vitreous base in that inferior area. That prevents the main objective is actually to prevent an anterior loop traction, an anterior PVR. Once you do that, the rest of the retinal detachments are easy, and the membranes also, when they form again, are easy to handle. So that's one thing. The second thing is about, which you showed also, about ILM peeling. Just for those where, when you went for surgery, if the vitreous was hazy, that's actually active PVR with a lot of inflammatory material. In those patients, one can consider doing ILM peeling at the posterior pole. That can prevent the recurrence of posterior PVR. And last point, that's a comment. I want to ask this from the panel also. You talked about treating symptomatic lattices. My question is, what about lattices which are posterior to the equator, lattices which are perivascular, and lattices which are radial, which nobody talks about? Would you like to treat them even if they are not symptomatic?
So in high-risk situations, you can, like supposing you have a very high myope, or you have patients such as sticklers who have inherently higher risk of developing RD. In these situations, you can treat lattices which are not the typical lattices which you see. Definitely you can treat, but in a non-high-risk situation, you can prefer to observe till the patient develops symptoms and till you think that that is the time to treat. You can observe them manually.
Anyone from the panel?
And the problem is, if answering this question will take us to the next tea break, so I will defer this discussion for later. I'll have Dr. Anand start. Yes, Manish, you have a quick comment?
Actually, a question for the panel. Is it that recurrences under gas, do they have more severe membranes as compared to the recurrences under oil?
The risk of hypotonia and anterior loop traction is a little bit more with gas, is what my perception is. But then, like PVR, because the globe is formed with oil. In contrast, here the access of the inflammatory mediators is all through the vitreous cavity, so it seems to have a little bit more anterior loop traction. Yeah,
I think it's probably more delayed because you will go in much later rather than anything else. So because there's a delay, it probably becomes more severe also.
Okay. Yeah, we'll go on to Dr. Anand Rajendra. You're going to talk to us about art of retinectomies.
Thank you. It's a pleasure to be talking to you about the art of retinectomy. I'd like to thank AIOC for having me here.
Thank you.
So, So going forward, I'm going to show you a bunch of videos. Yeah. So this is a kind of a prototype case of an inferior detachment with multiple breaks there. And this was a recurrent detachment. And as you can see, the first thing to do is to delineate, to assess the level of the extent of the PVR, and then go with your diathermy across, and you've determined that there's a lot of PVR inferiorly. And it's important to actually do a little diathermy beyond that area where there's PVR. Now putting in tricot, which I think is great to look for residual vitreous, and then going forwards. You also use the Thanos to remove any vitreous and complete the job later with your forceps, remove any residual vitreous there. And just go forward and remove that fibrotic pillar there. It's important to evert the edge to look for any subretinal PVR there, and then take care of that, remove all those fibrotic pillars. And it's important to freshen that edge as we go. You can see the little bit of PVR there. Make sure it's as fresh as a fresh GRT, so that you apply the same principles. And then once you're done with that, then you can put in PFCL. Make sure there's a single bubble. It's important to get that. A single bubble, put it in slow, lower your infusion, or even sometimes cut your infusion. Put in laser, good amount of laser, at least 3 to 4 rows, and then get your PFCL bubble above that edge, and then finally fluid air exchange and silicone oil. So this is another case where, again, a redetachment. There was an inferior broad buckle, and you'll see that in a little while. So here there was a sliver, a tongue of PVR going down posteriorly. So I do what I call a T-shaped retinectomy. So just take care of that little bit with a retinectomy as you go posteriorly, and then do a T-shape. And then you go all around and make sure you take care of that anterior flap, as you'll see coming up in a bit. And just move the video a little quicker to make things move. And you can see that the anterior flap is going, and the retina is there. And there you see the inferior buckle with the old cryo marks there. And we're putting in laser there. And it helps to have a bit of the retina attached. So that helps too much of torque from distorting the way the retina settles. And you can see putting in laser, and then finally fluid air exchange coming up. And you see a fairly decent result. So that was that. Then we move on to almost a PVR D1 open funnel RD, where the severe PVR all around. So you can see taking care of the pre-retinal PVR and putting in PFCL bubble. And then the peripheral parts are becoming bullous, though there is some amount of stiffness, and then going ahead with the same vitrectomy all around. And you can see taking care of the anterior flap. And this was a patient who could not position post-op prone, so we went in, put in PFC beyond, and then after that kept him for 5 days like that, and went in with a second stage later. And you can see the laser being put in. And now it's the second stage, and then replacing the PFCL with oil, and it did fairly well. So this is an even more severe case of a closed funnel RD PVR D3, where you see there's a small pupil IOL, and you see that operculum there. So we're opening that, I'm inserting that cutter, and then cutting up to expose that little funnel of the absolute closed funnel RD. And then I'm going to inject PFCL. You see this PFCL going in. And this PFCL, as it goes in, you can see it going in and popping out, and then actually, dissecting and pushing the retina against the wall of the eye. It's very stiff, and you can see it dissecting, and it goes back and forth, and then doing radial excision first, and then anterior circumferential excision, and removing all that stiff PVR there, and then going bimanual because it's very stiff, and then hacking away the left hand with the forceps, right with the scissors, curved scissors. You can see the posterior retina is now attached, well opposed to the wall of the eye, and then going past this, and then freshening the edge there with the cutter there, settling that part, and then removing subretinal membranes, and finally putting some laser after PFCL, topping up PFCL, a little more laser there, and finally So this is an interesting case that I did fairly recently. See, I've already done the anterior wide retinectomy, but there was this big triangular swath of nasal retina PVR. So I had this option of, actually removing that entire area, but there were two pre-existing breaks above and below. So what I did was just connected them, and then there's this blood clots and the PVR all messed up together. So I went now with horizontally across for the H limb, and then this is proving to be really tough. So I've resorted to the scissors, and then I had to excise it with that. You can see the struggle there. And then, evacuated, put in laser under that PFCL bubble. And this was the time the patient had an upshoot of BP, and you'll see a lot of subretinal hemorrhage happening. And with high IOP and, evacuation, little patiently, I was able to get that clot off. You can see the clot off. And then, again, laser all around, and then looks reasonably decent fluid air exchange, and then oil. Now, this is a case, again, I did probably late last year, Coates disease with, again, adult Coates, is tough PVR. And you can see the big triangular swath inferiorly. You can see the subretinal exudates caked below the stiff retina, and just getting that fibrous tissue off now, and then the tough PVD induction using the forceps, trying to get that off and hoping that that will do, but no, I realized that the retina below is too stiff, and I had to do a retinectomy, I had to resort to that, and there you'll see the subretinal exudates and that clot below mixed up with the muck of the PVR, and then evacuating all that. You can see that being everted and removing, and then finally fluid exchange, and then laser all around, and then finally putting in oil. This is another case of FEVR where you'll see something. Just finishing in 1 minute. Yeah. So this, you can see the gleaming vitreous and of the exudates, and the neovascularization, and then the tough PVD. And you can see a large horseshoe tear there, and then initially with the forceps, and then hacking away with unimanual, and then putting in PFCL, and you can see the peripheral PVR. This is where air is coming in, so it gives you three advantages. One, it gives you a panoramic view. There's peripheral neovascularization, the little wispy hemorrhage is also removed, and most importantly, allows you to assess the extent of the retinectomy you need to do. So you go ahead with that, and you're also at the same time removing the exudates and getting this in, and then finally putting in laser under that single PFC bubble, and then fluid air exchange, and then finally this settles. Yeah. I also just want to quickly show you that every case does not need
Anand,
large.
please conclude, because we are short of time. The session is going short of time.
Sure. Yeah. So this is just two retinectomies on either side, and you see with just those two retinectomies nasally and temporally, we're able to settle the retina with PFCL, air, and then finally oil. Yeah, thank you. Thank you.
Thanks, Dr. Anand. Next, I'm wondering if it was a mistake or something. There's an interchange. Mallika speaking on fibrin glue and Mudit Tyagi speaking on endoscopic vitrectomy.
We can swap. The more people speak on fibrin glue, the happier I am, sir. Yeah. All right. So thank you so much to the scientific committee, chair of the session, and AIOC for allowing us to speak on this. So I'll be speaking on endoscopic vitrectomy and how it allows us to usually obviate the troubles and the obstructions caused by an opaque media. Now, if you look at it, usually in eyes where there used to be an opaque media, our earlier approach used to be using a temporary keratoprosthesis. The problem with that is that subsequently you have to follow it up with the penetrating keratoplasty. So you need to put an optical graft subsequently. It also rules out custom corneal surgeries like keratoprosthesis immediately, and it's also got a relatively longer recovery time, and there is obviously a need for multiple procedures. Endoscopy allows us to obviate these problems and allows us to get away without using a temporary keratoprosthesis. It gives us an opportunity of a better visualization of breaks and membranes, can be diagnostic as well as therapeutic. The problem is that it comes with a bit of a learning curve, but that can usually be overcome. So let me just show you a few examples. So endoscope initially was developed in 1934, quite a long time back, but the modern day flexible endoscopes were something which were developed in 1990, followed by 23G probes in 2011. And this is how the endoscopy system usually looks like. This is the E4 system, which has got a light source, a fiber optic camera, and an endolaser unit which is built inside the endoscopy system. And so what you have over here is this fiber optic camera, which can be fixed over here with a laser probe, and which is fused with an optical fiber with 19, 23, and 25G microprobes, which are easily available now.
So this is the view that we have over here. And the thing is, what we need to understand is, unlike our conventional vitrectomy system, which gives us a bird's eye view of what we are visualizing, an endoscope gives us an end-on view. So what you will be visualizing is what the endoscope focuses upon. So you'll just have an end-on view, and that is the thing that needs to take time for us to get used to, and that's where the learning curve lies. But the good part is it gives us a field of view around 50 degrees in water, around 70 degrees or more in an air-filled globe. It also allows us to visualize subretinal, and if there's a subchoroidal or subciliary placement, then those areas also are easily visualized. So this is like what I was saying, this is how the visualization is. What you see over here is that you see a surgeon operating over here, and this video is not playing here. And you need to get used to look at the screen in front of you rather than looking inside a microscope. So you need to visualize it through a screen, and that's the other learning curve and the different things that we need to get used to. But the advantage is that it allows us to access these sites like ciliary sulcus, sclerotomy site, ciliary body, pars placata, and also obviously endoscopic endocyclophotocoagulation, which is done by a lot of our glaucoma colleagues. So I'll skip some of these slides because I believe in the next session I'm also talking on endoscopic vitrectomy in endophthalmitis. But I'll quickly show us how it helps us in a lot of these cases with also diagnostic endoscopy. So in eyes like this earlier, where we used to rely on either a B scan to visualize what's happening, endoscopy now allows us to visualize the entire disc status and the retina status, and therefore probably will help us in better prognostication in a lot of these cases. So these are images from one of our paper which we had published, where if you see this failed graft or eyes with keratoprosthesis, while an ultrasound reveals an attached retina, what we found when we did an endoscopic vitrectomy or a diagnostic endoscopy was a totally pale disc with sclerosed vessels. Again, in this eye, while a B scan shows an RD, an endoscope helps us in assessing a totally complete necrotic retina, an eye which was not amenable to further surgical interventions or a repeat keratoprosthesis. Thus, it helps us in prognosticating in these cases. So this is how, this was another eye which had a totally opaque cornea. Our cornea colleagues referred the patient to us for assessing the retinal status, and we found a total optic atrophy along with scarring at the macula, and therefore then we deferred any further surgical intervention in terms of a keratoprosthesis for this eye. In terms of surgery, how do we go around measuring from the optical cylinder? We can measure from the center of the cylinder, taking a distance of around 9 millimeter. It helps us in visualizing the cannulas and their location. And if inadvertently we end up going into a subretinal space or subchoroidal, that can be prevented. This was another one of these cases where we did a diagnostic endoscopy to visualize the optic disc and the macular status. But let me show you some more areas. Assessment of ciliary body structures, peripheral membranes, again becomes easy. We were earlier talking about how anterior membranes are such a big cause of PVR, and what endoscopy also does is it allows us to visualize these. So these are some of the cases where you can easily see a PVD induction can be done easily in these eyes once you get used to it. Membrane peeling, this actually is a video which I took from Dr. Rajiv Reddy. He was the one who started doing endoscopy the first time in LVPI, and the one who has actually taught most of us, me and Vivek and my other colleagues who do endoscopy right now. So another one of his cases, and this is what we were talking about. I'll just take 1 minute, thank you. So endoscopy allows us visualizing the entire peripheral retina, and this is where we were able to remove a lot of these peripheral membranes, what Dr. Talwar was saying about earlier about how anterior membranes are the ones which are more difficult to access. So these eyes, and this again was this patient who had a peripheral detachment when we went inside, and visualizing the peripheral retina, stabilizing the eye with PFCL, subsequently doing laser. All of these maneuvers can be achieved with the help of an endoscope. So in a nutshell, I'll come to these later on. Endoscope also, this was a patient, and Dr. Ritesh had a talk on foreign body removal. So this was a patient who had come with recurrent episodes of inflammation, and when we did an endoscopic visualization, what we found was that there was a foreign body which was located in the angle. So this was an occult foreign body which we were able to visualize subsequently with the help of an endoscope, and then we removed the foreign body subsequently. So in a nutshell, endoscopy allows us to overcome the challenges presented by anterior segment opacification and helps us in taking care of these eyes. Also gives us an opportunity of a very early intervention in eyes which would otherwise have been limited for either waiting for a temporal prosthesis or waiting for the media to become clear. Thank you so much.
Do you do endoscopic vitrectomy for patients who get chronic hypotony following a VR surgery, looking
So
for
we are doing it
cyclitic
now
membranes.
for some of our uveitic eyes and eyes which have got a chronic hypotonia. It gives us a much more better way of assessing those peripheral ciliary body membranes and trying to truncate and remove them. So we started doing them for our uveitic eyes and eyes with the persisting hypotonia.
And is it possible to do it as a bimanual procedure, putting a chandelier inside?
I have not tried it because if you are putting a chandelier, again there's a difficulty in visualization because you have got a light probe which is there along with the camera.
Yeah, so, but some of these cyclitic membranes don't come out on a unimanual basis. You need to...
So till now I've got away with you doing it unimanually, but yes.
Question, how you follow this patient in the post-operative period with the ectopic?
Sir, that is actually one of the biggest challenges for these cases. You can't easily follow up these cases. That's the biggest challenge that we have. While we can do an endoscopic vitrectomy at that point of time, put oil, but the subsequent follow-up is a challenge. We can just follow them on the basis of an ultrasound and see what's happening. But the follow-up has been one of the biggest limitations.
Yeah. Thanks, Dr. Mudit. That probably explains why very few people keep speaking about endoscopic vitrectomy.
Yes.
Shall I ask Dr. Malika to speak to us on fibrin glue in the management of complex retinal detachments?
Good afternoon. So I'll be speaking about my experience with fibrin glue to close retinal breaks successfully in complex retinal detachments with silicone oil in situ for tamponade. So glue-assisted retinopexy for simple rhegmatogenous retinal detachments without tamponade has been described earlier by Dr. Mudit Tyagi and his team. But this was done primarily to obviate the need for any tamponade. It has not been reported for complex retinal detachments with silicone oil tamponade. So we had a patient almost 2 years back, complex diabetic detachment. It failed after the surgery. There was an open break superior to macula. So we went in and after a little bit of membrane peeling, closed the hole with fibrin glue. The oil was already in the eye from the primary surgery. And 1 week later, the retina was reattached without any need for prone positioning also. So, the patient was seen after 8 months, and there was no inflammation, there was no oil emulsification, IOP was normal, and the glue was not seen. So encouraged by this, we took up a few more patients of complex diabetic RD. And as we do a dissection, there is some bleeding, some iatrogenic break, and then these breaks get covered by blood, which does not get dislodged. So difficult to laser these breaks. So after fluid air exchange and drying the surface, I instilled the two components of the fibrin glue sequentially over each break. And oil was injected. You can see the glue in the first post-op week, but it's not there by the 3rd week, and retina is nicely attached. So similarly, another patient, because of bleeding, laser was not adequate. So 2 breaks are being sealed with 2 drops of, with the 2 components of the glue after fluid air exchange and drying the retinal surface with good attachment post-operatively. This is a situation where the break is very close to the foveal center, so we don't want to do laser in that area. So after releasing the traction, the 2 components. Now here we injected the less viscous component first, so there is a large collection pool. However, it has plugged the hole very well and the retina is attached. So then we extended it to non-diabetic detachments. Generally, when we have a macular hole RD, we are able to close it by doing an ILM peeling, but sometimes ILM peeling is not successful or it's a failed macular hole RD, like this one was a failed RD. So you can see that we instilled the glue over the macular hole and it's attached. Similarly, a young boy with a chronic, very old RD, and macular hole was the only obvious break. So after doing an ILM peeling, we put some glue for additional security. And by the 6th day, we can see the glue, but by the 10th day, it's almost gone, plugging the macular hole, and you see the good result with no adverse effects. Now, in this patient, ILM peeling could not happen. So you see the hole is still open, but the RD has closed, RD has settled with the macular plug of fibrin glue. So the only things that we realized during the technique is that the two components should be drawn separately in two different 2 ml syringes rather than 1 ml, because 1 ml is longer, more difficult to maneuver. And it's better to inject the more viscous blue top sealer protein first, so that the amount of injected material is less and you don't have a large pool. So you can remember it as blue top first, blue first. And the other is that these needles get blocked before you can inject. So first squirt out some material before going into the eye, because if you try to overcome the block close to retina, it comes out with a great force which can enlarge the retinal tear and lead to excess pooling as well. And in general, avoid excess injection. That is the commonest problem. Just 1 or 2 drops is enough. But this is difficult because it's each component is transparent, and even when they mix together, they remain transparent for a few seconds. So the surgeon is not sure how much has been injected. So the tendency to over-inject has to be curtailed. Now this was a patient which by chance I realized that the glue post-operatively has gone subretinal, you see the track, and then it has been within few days we see there is atrophy in that area. So this means that we should be very careful using it for macular hole closure where we don't want perifoveal atrophy. And similarly, excessive injection even in a peripheral break can cause it to go subretinal, causing the break to remain open, which can cause a persistent RD actually. So in this patient, we had to reoperate and it reattached after additional membrane peeling. So in summary, fibrin glue can be a useful adjunct in the management of complex retinal detachment, especially when laser for retinal breaks is not possible due to bleed, edema, or proximity of break to the macular center. The glue resolves very quickly and is not seen even as early as 1 week after the surgery. There are no adverse effects with silicone oil in situ. There is a rapid retinal reattachment compared to when it is not used, and the need for post-op positioning is reduced because the hole is already plugged and does not depend on the laser effect to come in 2 weeks' time. But we should avoid routine use for macular holes, as it can in some cases cause retinal atrophy when it migrates subretinally, and it can move subretinally and keep a break open. Thank you.
Excellent presentation, ma'am. Just wanted to ask a question that, do you have any experience of using the glue over a retinal autograft in a failed macular hole?
I haven't used it for macular hole at all. I've used it only for retinal detachment till now. I've never used it.
We have tried placing it over a retinal autograft and we were using it for failed macular holes. All 3 times, somehow the glue was not to be found anywhere post-operatively. That's why I was asking that question.
That's an advantage if it dissolves quickly, but at least first post-op day, I think it should have been seen. Maybe the patient.
So, Dr. Malika, very nice presentation, but I just wanted to ask you that what about the permanent retinopexy? Because here, as you mentioned, that you're not doing laser, and you're showing the advantage that when there's blood or edema, when you're not able to do laser, but after the fibrin glue disappears, then what happens? Because breaks open up.
Yeah, so what happens is most of these patients, it's not that we didn't even try the laser. We have already attempted laser, but it was not adequate. So I think if the retina is attached because of the glue which plugs the hole, possibly that laser pexy comes in. And I have not had to touch them up post-operatively, and none of them have reopened.
But you didn't do the laser?
No, we tried. We did try, and this was given after we tried and we were not satisfied with what we got. We tried.
The question of using it as a graft. So the problem is that we have not used it for retinal autograft, but we tried it for autografts, allografts. The problem that happens is that when you put fibrin glues a liquid, it sometimes tends to displace your graft. That is the first problem. The second is for the question that you did not see the glue immediately the next day. Is it that you put both of the components, the thick one and the thin one together, or was it a fresh glue?
No, the technique that you had shown in DRM, first the thick one, then the thin one.
So then ideally the next day you should see a coagulant. Did you also use air by any chance?
Yes.
So probably the next day, by the time you assess the retina, it was the 6th day or the 6th day, and you did not find it? Or
further discussion you both can have over coffee. Thank you so much.
Thank you so much.
Can I ask Dr. Saumil Sheth to present his favorite topic of limited vitrectomy?
Thank you, sir. So every time I present this, I usually find you as a session chair. So very sorry for hammering a concept onto the audience that is simply not willing to, that's still very controversial, not going to accept that easily. So anyway, my in fact technique is gaining a lot of momentum because of pneumoretinopexy that is very much in vogue these days. So the theme is basically less is more. Do as less as possible. When the world is doing exactly the opposite, they are so obsessed about removing every single strand of the vitreous. So my path is more of the middle path kinds, where I do neither. I don't do a pneumo, nor I do a complete vitrectomy. I do a limited vitrectomy. But that does not mean that I do a lazy, shoddy, half-baked, half-hurried kind of a vitrectomy. So I do what I say when I say limited vitrectomy, is that I don't induce a PVD. And the first step in limited vitrectomy is limited vitreous removal, enough to get a full air bubble, so as to avoid fish eggs and more importantly, avoid opposite side traction and new tear formation, which is sometimes seen in a case of PNR. Limited SRF drainage to oppose, just adequate to oppose the retinal break to the choroid so that I can get my laser through. This partial drainage avoids retinal vessel displacement, which a lot of people are talking about these days, or receptor ISOS healing because of immediate absorption and malapposition of receptors. And limited barrage laser to culprit retinal breaks in one sitting itself, which avoids a lot of post-operative cumbersome posturing that you see in PNR. And you need to follow up these patients every now and then with PNR. You don't need to do that in my technique. So PNR versus limited vitrectomy, these are the advantages, but the principle is basically the same. To put my technique in a small video, what I do is just locate the breaks, and I've done a limited vitrectomy in the vitreous cavity. Just note that we have not induced any form of PVD, and while I'm cutting or put in my flute needle under the break, I'm doing an air fluid exchange in a way that just is enough to flatten the break onto the retina, either laser or cryo the break. I need not drain the fluid that is posterior to the break, and then keep air inside or gas it. So that is basically the time that it takes. It's really very rapid. But the important thing I want to emphasize here is that this concept is very counterintuitive. When I say no PVD, how can we have a retinal break or an RD without some form of PVD? A lot of people would ask me this, and I believe that RDs, especially in patients with myopic holes with lattice, as also retinal dialysis, have no PVD, as holes in these cases are caused by tangential or circumferential or stretch traction, similar to what you get in macular holes, because please note that all these holes do not have an operculum. In holes with operculum, there is some form of PVD, and for me, they are similar to horseshoe tears or completely plucked horseshoe tears, and I would tread with caution. I'll not use my technique. I'd rather do a complete vit. Also, in these same group of patients, young myopic RDs with holes and lattice, if there is no PVD, there is no hyaloid ILM separation, and there is hence no space for RP cells to migrate to cause PVR. So when these RDs go chronic, we must have observed that PVR is mainly subretinal in the form of subretinal bands. If there is any epiretinal form of PVR, it means that there is some component of PVD present, and I would rather do a complete vitrectomy. And when I say complete vitrectomy, I would do what everyone does, where more is more, try to remove every little strand of vitreous. So my indications do not apply to cases where there are frank HSTs or some form of PVD present. They apply purely to those young group of patients which have retinal detachments either because of retinal holes, lattice or dialysis. And those are primarily the kind of cases which otherwise people would have scleral buckled and not done a vitrectomy, because when you do a vitrectomy in such cases, especially in young patients, you land up with a whole lot of problems because of difficult PVD, incomplete vitreous separation up to base. Even if you succeeded in inducing a PVD, iatrogenic tears, PVR redetachments and cataracts. So this is primarily the reason why you do it, because the vitreous is only half removed. Even with your best efforts in such cases, there is this scaffold between the vitreous and the bare ILM where the RP cells proliferate to cause PVR. If you see this video here, you see that it is very difficult to actually induce a PVD in such cases, so much so that after making a lot of attempts in trying to induce a PVD, in the last attempt that I'm making, the retina is actually coming along even in the completely attached area. Here it is detaching the retina rather than lifting the vitreous of the hyaloid, of the disc. But in these cases, if I still want to do a PPV and not a scleral buckle, and yet want to avoid all these complications that I mentioned, what I do is I don't induce a PVD at all. And this is very similar to the pneumo technique, except that I'm allowing a larger air bubble to go inside in between the vitreous fibrils by cutting them off rather than insinuating it. So here the principle is the same. Buccal is over-clarified because I feel that it is actually the vitreous that is attached completely that is preventing PVR, and MIVS is over-criticized because what we are taught in doing while we are doing MIVS, that as soon as we enter the vitreous cavity, we are told to do a PVD. So it's a very, very controversial technique, and I have received my bit of criticism, especially from a lot of people on the panel itself, because preferred practice pattern is exactly the opposite. Textbook concepts are opposite, but the same applied to PNR till recently. It has gained a lot of traction. So if I have to name my technique, I would probably call it as minimal or limited vitrectomy, bowl or coal vitrectomy, or hyaloid preserving vitrectomy, or no PVD vitrectomy. The fringe benefits that I get, or side benefits that I get out of limited vitrectomy is no buccal, no conjunctival opening, no refractive shift, no cataract, and surgery takes probably about the same time that I've been allotted for this presentation. Thank you.
Sir, you have been telling only your personal experience. Is there any RCT for this, comparing this with that of? Because that is the one which is going to be the evidence for us, actually. So this will be sort of like a personal opinion. So how many cases you have done, and what is the reattachment rate in all those cases? And one more thing, how many are inferior breaks and how many are superior? Because it is similar to pneumorectopexy, people also said.
So this I've been doing since the last over now 5 years, and would be around between 90 to 100 cases that I've done. There has been only one redetachment, and probably I feel is because it was a case where I thought there was no PVD, but there was, because immediately post-operatively there was a redetachment because of a PVD. Except for that one odd case, there has been practically full success. So I would say 99% success in such cases, and I do not differentiate between superior and inferior breaks. I don't feel that it is the gas tamponade that actually closes the break per se. The gas is not used as a tamponade in these inferior. It is in fact the vitreous, formed vitreous itself, which is going to close the break once you've drained the fluid and got your laser into place.
No, but why do you feel that a PVD caused the detachment?
I don't feel.
You said that about not that the case which detached.
Yes, I thought that it was a no PVD detachment, which actually turned out to be a PVD induced.
So why did that cause a failure?
So it could be either that my technique must have immediately induced a PVD because of some handling in the vitreous, and that could have caused a PVD immediate post-op and could have caused new break formation similar to what you see in a PNR and could have caused a redetachment, or it was a PVD to begin with where I did not separate the entire vitreous. In my technique, I don't attempt a PVD. So it must have been a partial PVD to begin with. It must have become a whole PVD after I finished my surgery, and that led to a redetachment. So there was this one odd case, yes.
Yeah. Thank you very much, Saumil, and we will proceed with the next speaker, Dr. Pradeep Kumar. He will be speaking instead of Vinod Agarwal, and he will be dealing with supine position for post-RD surgery.
Very good evening, everyone. I am presenting this topic on behalf of Professor Vinod Agarwal, and thank you for this opportunity. I'll be speaking on an extremely counterintuitive topic right after the first one. So we are talking about supine positioning after RD surgery. So tamponading agents have been used basically for providing surface tension across the retinal break, to maintain the intraocular volume post-op, and to create a rhegmatogenous confinement for the retinopexy to take effect. Now these patients were post-operatively placed in prone position. But most retinal breaks commonly develop in the area which is anterior to the aura, anterior to the equator, and they will be better tamponaded in supine position. So this was the thought process. In the first slide, you can see that when the eye is 100% gas filled in prone position, the anterior breaks are quite well supported. But the moment this bubble falls to 50 to 60%, those breaks are likely to be unsupported. But if you place the patient in a supine position, you will realize that these anterior breaks will remain supported even when the tamponading bubble becomes smaller. So there was one single prospective study which had examined this supine versus prone positioning earlier. So we designed this prospective study with a primary objective to study the anatomical outcome and a secondary objective to assess the best corrected visual acuity, the IOP changes, and the change in the phakic status of the patient. So 72 eyes of 70 patients were randomized, 37 in one and 35 in the other group. Our inclusion criteria mainly involved fresh RDs, patients with PVR less than C2 grade. And we avoided younger, extremely young and older age group so that whichever positioning we gave to the patient, it could be adhered to persistently. We avoided combined reg RDs, so we chose these patients of fresh RD presenting to our OPD. Those meeting the inclusion and exclusion criteria were recruited. PPV was done in these patients, and they were given their supine positioning or the prone positioning, and these patients were assessed at 1 week, 1 month, and 3 months. So this was the standard surgical technique which was done in all these cases, and the choice of gas remained between SF6 and C3 F8 based on the surgeon's discretion at the end of the surgery. This very cluttered slide talks about the preoperative status of this patient. I'd like you to focus on para 10, where we talk about the number of breaks. These are primarily patients with one break, and the position of the break was mostly superior, but yes, in both groups. 8 patients in group 1 and 7 in group 2 had inferior breaks also. The primary outcome was that 36 patients, that is 97% in the supine group, remained attached at 3 months. There was one redetachment, and 33 patients, that is 94%, remain attached in prone group. There were 2 redetachments. There was no statistically significant difference between these two. This figure of 1 and 2 is too small to say that there is a difference in the outcome in supine or prone. So they were comparable results. When we talked about best corrected visual acuity, the groups fared similarly, and so did the intraocular pressure. So the plausibility of supine positioning with gas causing a rise in IOP was not there. 3 patients in supine and 7 patients in prone position underwent cataract formation and later on surgery at the end of 3 and 6 month period. The post-operative complications were comparable between the two subgroups. There was formation of ERM in 2 patients in supine and 3 patients in prone group. There was neurosensory detachment. These were the cases which had those redetachment, 1 in supine, 1 in prone. CME occurred in 2 patients in supine, 1 in prone. Vitreous hemorrhage was seen in 2 of the prone patients, and macular hole developed post-operatively in 1 patient in each subgroup. So they were all comparable. So these are examples of what happened to these patients pre-op and post-operatively. So these were single horseshoe tear, they were lasered well and have settled. And to conclude, we'll say that single surgery retinal reattachment was similar in the 2 groups. There were no increased complications of cataract formation or IOP, which were suspected by many patients many of our colleagues when we were discussing this idea. And both the positions work well. One should be encouraged to try supine positioning in at least some of their patients. The limitations of this study have been its small sample size and less number of patients with inferior breaks. To end the study, this is one video that Dr. Vinod has tried to submit where he says that once you introduce tamponade, this kind of turbulence which you see inside the eye, that gets settled down once air keeps filling the globe. So he says that once air has gone in and the turbulence is settled down, see once the air enters, you are seeing the movement of all those detached ILM peel fragments that stops. So once you do not have turbulence inside, supine positioning will work as well as prone positioning. There have been a lot of critics to this, but our publication is now in Retina and will be out soon. Thank you, sir.
Pradeep, it's a little surprising that the supine positioning caused less cataract than the prone one.
Exactly, sir. When we were discussing this idea, that is what everybody said, that we will have a lot of cataracts in our subgroup, but it did not happen that way.
Phakic patients was the same in both the groups?
Yes.
Actually, you need to analyze the number of breaks and the position of the breaks also. while having the results?
Sir, that is where that slide I had shown para 9 and 10. The position of our break in both the subgroups were in the superior half in almost about 3/4. But in 1/4 of the patient, they were inferior or temporal or nasal. So that is.
Superior breaks do not matter whether which position you are giving, but the inferior breaks actually matters, and probably you need to do a subgroup analysis to authenticate your proposal.
Oh, yes, sir. In fact, it's no longer a proposal, it is a completed study, sir, and it's been accepted now. Thank you.
Upon the next speaker, none other than Karobi Lahiri. She's relaxed. Surgical nightmares. Please help her. You will get a chance. Not.
No, I think this is Mangat's stage 4, stage 5 ROP. Come.
No. Surgical nightmares, Dr. Karobi Lahiri. Yours is there. We are testing you, how you can.
Good evening, judges and my fellow colleagues. I'm going to talk to you today about surgical nightmares. When you have cases like this, you enter the OT with trepidation. You may have a brow which is sort of frowning or probably sweaty, and you have to go and make the best deal of the worst kind of situation which is facing you. So let's look at a few cases. This is a 65-year-old patient who came from Indore. She had multiple surgeries in the past over nearly 10 years at Indore. She was one-eyed. She had glaucoma surgery in one eye, cataract surgery, 3 keratoplasties, and she was surviving with hand movements close to face vision, with which she was managing all her activities. Then she has an injury with a bedpost, and that visibility went down to seeing a shadow since 20 days. She then came over to Bombay, and her USG showed kissing hemorrhagic choroidals in that eye. Now, just look at the gruesome appearance of this eye. A lot of panels, 3 keratoplasties, so you can imagine what was the status. Glaucoma surgeries, there was filtering site, and this was, one had to really think out of the box that what and where would we place the incisions for the suprachoroidal drainage. So let's have a look at the So we placed AC maintainer in that eye, and we went further back to the height of the choroidal, much beyond, and we did our drainage from that site. We had kept a graft ready because that day I did not have a temporary keratoprosthesis because it was stone, and I needed to put the graft and then do the surgery. So after I felt that the returning fluid was clear, then we went ahead with the graft, which was sutured in place, did the vitrectomy thereafter, and after creating a lot of mark, there was still a little bit of residual blood. We've done a fluid gas exchange. So reasonably okay. I put a buckle all around so that there was sort of good tamponade, because I didn't know whether there was a break in the periphery or not. Now the case number 2 is a history of cataract surgery which was done elsewhere. Patient was on blood thinners, had not stopped that before the surgery. There was suprachoroidal hemorrhage on the table. The clearance was attempted somewhere else after 14 days of surgery, and then she was sent for an opinion after 1 month for treatment of residual bleed with a contracted retina. So this was the patient. A 3-port vitrectomy was done. There were areas of pooled blood which was removed. The retina was highly contracted, and there was blood lying pre-retinal and under the retina, surface of the retina. It was a highly contracted retina with a blood which was congealed in the periphery. There were a lot of membranes under the retina, which was meticulously removed. And one really didn't know how this case would fare, but then we were giving it our best shot. All the membranes were carefully removed. And then we used a brilliant blue dye to stain the ILM, and the ILM was carefully removed. And then a lot of massaging and coaxing the retina happened to allow the retina to become a little compliant with what we were trying to achieve from it. And after a lot of back-breaking work on the retina, where the periphery was then, it was converted into a large retinectomy. We were able to settle the retina, the laser being done for it, and then the PFCL was removed towards a good conclusion of a horrible case. Now, this was a 74-year-old lady who had history of brittle diabetes, hypertension, cholesterol issues, hypothyroid. Stenting was done in the past. She was on 13 oral medications, inclusive of blood thinners. She had cataract surgery for a hard cataract, had a nucleus drop, which was removed with vitrectomy PFCL through lumbus, as it was resistant to sonification, with a resultant suprachoroidal hemorrhage on the table, which was dealt later after 18 days with vitrectomy and a suprachoroidal hemorrhage drainage. This is a very hard cataract, and on sculpting, this had descended into the eye. The surgeon had done a vitrectomy with a removal through the limbus, and then it was repositioned, and at the end of surgery, after the sutures were taken, the suprachoroidal hemorrhage ensued, which was the cause for it being a nightmare case. And then later, this was drained, and it was kind of dealt with. But
Karabi, 1 minute.
yeah, but the ultrasound on the right shows, just a moment more, it shows an attached retina, but if you see 3 months later, the patient redetached, and she had to take some time because she was not well, and she went in for surgery again at a prime institute after 5 months, but she bled again on the table on the completion of successful detachment surgery. So this case was doomed to failure. I'll just show one more case. Can I?
Running eggs.
Okay. This was another case where we have done a TKP. Finish. Okay. This will almost get over now. A TKP was done and a vitrectomy was done through it. The conclusion was good of this patient. Thank you so much for your kind attention.
Yeah, thank you, Karabi. And I invite Dr. Mangat to speak on stage 4 and stage 5 ROP.
Thank you for inviting me to this session. My slides, please.
Dr. Mangat Dogras. Audio visual.
Okay.
Yes. You got it.
Well, friends, I'm going to talk about mainly stage 4 and 5 ROP.
These are my financial disclosures. I think one thing we must keep in mind that we are doing something different than what we do for adult surgery, and there will always be discrepancy in the anatomic and functional outcome, and we have to consult patients very well. That is the most important part, and take an informed consent. And one of the biggest problems which we are facing, and some of us, those who want more people to do surgery, they have a problem with anesthesiologist not being there and also not having a support of a pediatrician or neonatologist. I think these are the different approaches which are done. Sterile buckle, already Subhadra talked about it, but it is rarely performed. There was a time when this was the major surgery. In fact, this was the perhaps the surgery performed. But with lens-sparing vitrectomy, which became more popular, the sterile buckle went down. Then the lensectomy and vitrectomies are required for advanced cases. I think the indications are 4A, 4B, and stage 5 ROP. And if there is a progression despite your laser or anti-VEGF treatment, I think these are the cases most important. Go for the surgery, you get rewarding results. Sometimes there is a dense vitreous hemorrhage, and of course, all bilateral cases you would require surgery. I think we did this little study that time when laser was being done for AP-ROP, and we realized that if there is a pre-existing or a new fibroproliferation coming after laser, these are the cases they'll not do well and go to detachments. And posterior zone 1, most of them go to detachment. That's what and of course some of the other cases also. I think lens-sparing vitrectomy is something which has really revolutionized the surgery and has done a lot of good as far as 4A, 4B is concerned, and this has given the best results. The literature reports anywhere now, even there is recent data with some of the studies have reported even up to 97% the results, but these are some of the studies here, mostly even from some from our own country. I think if you have a situation like this, you can see that exactly you have a proliferation already there, and once you see this and it goes fast to detachment, and you can do a lens-sparing vitrectomy and give a reasonable outcome. Another case, you see, these are cases where they appear that it might be much more serious issue. You have to just cut these bands, and you would find that the retina would go back. That is what happens. And more severe case, I'm not showing the video here, but even a case like this where the whole retina has come and crunched right over the optic disc can also open up. We did have few of our own newer innovations in a way that one is, of course, that you partially put in the trocar and push in, don't push it in all the way because these are small eyes, and all nasal, which would help to preserve the lens, especially in the temporal RD, is something which is very important, because once we sacrifice the lens, then the whole advantage is gone. So here, what is done is that you put in this cannula right in the nasal, sit on the nasal side, and then go on either side. That is the idea. And I think it achieves all the surgical objectives, and you would preserve lens in most of the cases. I think this is a small video which shows the same procedure. I basically want to say that this nasal infusion cannula which you put, it is supported by the nasal bridge. You feel so comfortable. You will feel more comfortable with this rather than putting on the temporal side, which usually tend to bend down at times. We have to keep it up, supported. And you can achieve most of the surgical objectives, even in a case like this, which in fact, if you will see here intraoperative OCT, you will find that the whole retina here is temporally coming up all the way to the periphery, and we would have to remove the lens in such a situation. So I'm not showing you the whole surgery because my time is going to be over here. But you can see the retina, how much contracted it is, and look at that intraoperative OCT. It has gone all the way up, and that is what happens here. So I think basically you're just going to cut whatever is possible possible, open up, and I think I'll just skip the whole thing here, and this is what you have finally, the same retina. And another case, again you can see, and how well it will go back. And we did have 8 cases in this particular series, which is already published in Retina in 22. And of course, stage 5, I would mention, I think I have done very few cases. I used to do 4A, 4B very, very commonly. That was the commonest surgery, because lensectomy, only 1/3 would achieve results, and usually visual results are poor. But I think one should go through this newer classification. If you have an open funnel, then perhaps you can definitely go in and you will achieve this. This was one such case here. Again, I'll skip this video. What I would say is that lens-sparing small gauge vitrectomy is the most important ROP surgery for 4A, 4B, and early lens-sparing vitrectomy. That is what is the key. If you can do it at 4A, it is progressive, you get the best results, and you do very little. Technically, it is not difficult. The problem is you need a full support. That is what is required. And of course, lensectomy, vitrectomy is required for stage 5, and you do follow this newer classification. In the C group, I think most of the time we don't get anything, but I think in the first 2, especially if it is an open funnel, you maybe get some good results. Thank you very much.
Thank you very much, Dr. Mangat. Any questions for Dr. Mangat? I think no one will dare to ask you questions. Okay, with this we are coming to the end of session 4. Actually, this is a retina subspeciality day, and we will be going for the session 5.